I'm good. I think we can start. We've done with the pre-test. And we have both Dr.
You
C.P.
are not
Kapoor
audible,
and
sir.
So you're not audible.
All right. Yeah, I'm not at home. So, yeah, I hope I'm audible now.
Yes, sir.
yes,
Yes, sir. Yes, sir.
Right. Yeah. Uh, I always look forward to these STG sessions, the standard treatment guideline sessions. And for those who have joined us for the first time, I'm happy to share with you that National Health Systems Resource Center and Delhi Society for Promotion of Rational Use of Drugs. Dr. Sangeeta Sharma is the president and representing this thing. Together, we have been running these STG webinars for the last 3 years, and this is the fourth year and the second session of the fourth year. So it's been a good run, Dr. Sangeeta. What do you say?
definitely. Even I also look forward. I'm so fascinated by the response by the people, and it's quite satisfying to know that they find it useful in their clinical practice.
That's wonderful. So we have a large gathering once again today. I think the topic has evinced a lot of interest. Welcome, Dr. Ritika and Dr. Seema. We are privileged to have you with us today to take this session forward. Thank you. Yeah. So just to bring everyone up to scratch, this is the 38th session that we are having. Uh, these sessions have been very popular. 3 years it's been running. This is the fourth year, as I was saying, and a variety of subjects have been covered. The idea is to promote rational treatment. Um, if the treatment is not proper, it is not as per standard treatment guidelines, we risk uh, adverse events and obviously poor outcomes are there. So we have been helping these sessions for 3 years now. The previous session um, was the first session of this year was very well attended. Um, and now, today we have sickle cell disease. This has been recognized as a problem at the national level. And under NHM, the National Health Mission, we are supporting management of sickle cell disease, required um, medicines, and even plasma factors are included in the National Essential Medicine List. Uh, Dr. Sangeeta, would you like to add to this?
No, I think we can, you know, carry on with this session.
Right. Okay. So, Dr. Shreya, will you please take this forward?
Sure, sir. Sure, sir.
Introduce our first speaker. Yeah.
Very good
Thank
afternoon to
you.
everyone. I'm Ms. Shreya on behalf of Quality and Patient Safety Division, National Health Systems Resource Center, New Delhi. Extend a warm welcome to all the panelists, to all the dear participants, to this 38th STG webinar series. We have been for stepping into the fourth year, and this is the second session of the fourth series. To continue further with the session, I would like to invite our first guest speaker, Professor Seema Kapoor, ma'am. She's currently working as Director Professor, Department of Medical Genetics in Maulana Azad Medical College and Associated Ellen Hospital, New Delhi. She is also the State Nodal Officer for Rare Diseases in Delhi, and she has also worked as a State Nodal Officer for Blood Cell in Delhi. She's also the Director for Genome Sequencing Unit in Lok Nayak Hospital, New Delhi. Her area of interests are newborn screening, followed by biochemical genetics and mass spectrometry. And she is experienced in medical and pediatric education. Along with, she has authored 208 indexed publications in national and international journals. She is a recipient of awards and recognitions. To name a few, we have MS International Signature Award for unparalleled contributions to genetics. She has been awarded 25 gold medals during MBBS and awarded the President's Medal for Best Lady Medico in the year 1982. And also to add one more recognition, she has been an International Travel Award to Self and has PhD students for JDDW 2018, APDW 2018, and SSIEM 2018. Today, she is going to take up the session on sickle cell disease, management at secondary care, and implementation challenges of sickle cell anemia elimination program. Over to you, ma'am.
Thank you so much. It was a very kind introduction. Probably I could have done with a shorter one. Yeah. So, and I thank
But you
NHS
deserved this.
for
You
giving.
deserved this.
Thank you so much. Thank you so much. So, I thank NHSRC for holding this seminar. So, there might be times that I'll be taking the water on because I have a little problem at the moment. But I'm going to basically touch upon secondary care and implementation challenges very briefly because that's a full topic by itself. So for next slide, please. Yeah. So of course, a very basic thing you all know, that's the most common inherited disorder of hemoglobin, nothing less than thalassemia. Now the difference between sickle cell and thalassemias are quantitative defects in the alpha gene or the beta gene. While sickle cell is a qualitative defect in which at position 6 of the beta globin gene, which accidentally has only 3 exons and 3 introns, a very, very small gene, and a single gene change at position number 6 by another amino acid can actually cause this disease. Now, this amino acid change makes the body sickle cells have a different oxygen capacity as compared to normal hemoglobin. So that's the basis. Hemoglobin, like thalassemia, you may not require transfusions every 15 days. Or in certain situations that I'm going to discuss, you may require oxygen transfusions. So this is associated with the right. I'm going to go through next, please. So why are we actually looking at the background? Next slide, please. Yeah. So if you look at the population in sickle tribes, you would find 1 in 86 birth having at least one allele affected with sickle cell disease. And this is the largest data ever published yesterday by ICMR and Department of Biotechnology, who have collectively screened 1 crore 13 lakh 83,664 individuals in these closed tribes and communities and found that at least in 8.75% people, you have one allele affected. That means you are a trait, and 47,311 those who have disease. So a trait, because he carries a normal allele, functions mainly near normal, while a disease where both the alleles are gone has definitive disease. So that's very important to realize. And these terms are called AS and SS because the normal hemoglobin is hemoglobin A and the sickle is denoted by S. So a carrier is AS and an individual who is affected is SS. A little bit of the physiology will be taken in the next lecture. Basically, the abnormal adhesion to the vascular endothelium, which triggers a cascade of inflammation. This leads to altered nitric oxide metabolism with an exacerbation or flare. And the question comes, these RBCs are not folate deficient. So why do we need to treat them with folic acid, which has been the treatment for last maybe 7 to 10 decades? Because such a fast RBC turnover. The erythroid series does not compensate similarly with the chaperones, which are folic acid and B12. So you have to supplement folic acid in children or adults who have sickle cell anemia. Also, because they have a very high chance of risk with encapsulated bacteria, I'll tell you later why. It's important to start penicillin. Now we are actually looking at no penicillin times at the age of 5 years, children less than 5 years, or those who have been splenectomized because they do not have properdin to capture these encapsulated bacteria. Next slide, please. So I wanted to understand the difference between a carrier and a so carrier diffuser prevalence could range from 1% to 35% in certain tribal belts. And there is the central India, mainly Madhya Pradesh, Chhattisgarh, Orissa, Maharashtra, and Gujarat, which in the center have actually the belt where sickle is most commonly found. But they may have concomitant gene, which may be thalassemia. So they could be having sickle beta thalassemia, they could be having sickle HBE disease. So when you have another disease, you call it a double heterozygote, right? But if you have a, for example, thalassemia has multiple mutations. So if you have a different mutation at one locus and a different mutation at another locus, you call it compound heterozygous. I hope this is very, very clear. Sickle carrier means only one allele, that means on one chromosome, which is normal, and the other chromosome, which is having the abnormal structural variation. But this normal individual, like 1 in 400, who do not have a kidney, they have a solitary kidney, and they never ever get to know that because the other kidney compensates. Similarly, in carriers, the normal allele nearly compensates for the consequences that occur. Now, such a wide prevalence has been addressed by the Honorable Prime Minister of our country to launch the National Sickle Cell Elimination Mission by the year 2047. Next slide, please. So, are we looking at treated patients today? And how would we reach 2047? I'll just discuss a few things and then go to you. Now, we have an excellent drug, which is hydroxyurea. We also have L-glutamine, pridazole, and voxelotor as other drugs which can help in sickle cell disease, while hydroxyurea is a really cheap, good standard of care, which is to be given in children who have recurrent acute chest syndrome, which I will just explain, or who have such crisis for more than 3 times per year, which may be vaso-occlusive or could be acute chest or could be strokes. So there are three major issues here. You can have vaso-occlusive pain crisis, you can have a chest syndrome, or you could have strokes. There have been issues about fertility, recurrent infections with hydroxyurea. So it's not without its side effects, but compared to its effects, the side effects far lower than its effects. Next has come the India's initiative to impart hematopoietic stem cell transplantation. The issue here is you need an haploidentical, either sibling or parent or from the registry. But usually these are not available because the registries are not very sound. We don't have an ICMR, DHR monitoring to keep the registries in place where you could find your own haplomatched donor. So it actually goes to half haplomatched or unrelated donors. And once it is unrelated or haplomatched, there are always chances of rejection. So what next? Now, these hematopoietic stem cells, they go inside and they replace the abnormal cells. But if we modify these stem cells itself and insert the normal gene in them, this patient will be able to live life absolutely normally. So once we have on the scene ideal gene therapy coming in the last 2 to 3 years, we can surely, by three methods, actually eliminate sickle cell from our country. The advantage of these hematopoietic stem cells are that they have the ability to generate multiple blood lineages, and therefore, year after cycle after cycle, the gene corrections persist from the erythroblast to the erythrocyte, and this keeps on occurring. Next slide, please. So how do you do these stem cells? You harvest them from bone marrow, or you mobilize them by giving cytokines like GCSF or GMCSF, or there's another method that you enrich the CD34 fraction, which is the signature of these hematopoietic stem cells. When you use these in preference to the other stem cells, the hematopoietic stem cell numbers increases 30 to 50 times. So even in the first infusion, you get a real good response. So what does this do? When you actually, the protective phenomena or the methods, whether it's hydroxyurea or this, the main thing is to increase HbF. Now here you would understand, while sickling does not immediately appear in infancy, while by year 1, you most commonly diagnose thalassemia because there is good amount of HbF till about 6 months of age, and it starts declining rapidly thereafter. And it is then, because HbF is protective in sickle cell, it actually clearly mimics the action of hydroxyurea. And I would tell you one other drug, which is not known now because the birth defects that it causes, especially the limb defects, which is thalidomide, which also acts by activating HbF. Similarly, there are many more genes which promote HbF, one example of which is BCL11A. I don't want you to remember these names. The basic message here is that any action that increases HbF production protects these sickle cells from becoming deoxygenated fast and therefore will work in a patient with sickle cell. Now that we have so many therapies and even gene therapy from India coming in, we have to be on our toes to let these children have the least effects of the disease and make them good candidates for a hematopoietic stem cell or for gene therapy as it takes us. Next, please. So a little bit about the pathophysiology. So it's a deoxygenation which leads to HbS polymerization. This polymerization causes sickling. Once there is sickle cell, and this actually there is an aggregate, it obviously leads to hemolysis. And therefore, in this, there is nitric oxide depletion. These sickled RBCs, they actually go and stick into the microvascular. So, for example, the end of the fingers, there is an end artery. The end of the renal glomeruli and tubules, there is an end artery. The vessel in the eye is also an end artery. So obviously, here you can see what all could be the complications if these microvascular vessels get obliterated. Next, please. So how do you take care? Obviously, I'm going to deal with primary care. My topic is mainly secondary care, but just to explain a parallel diagram, the primary care has the responsibility of early screening of sickle cell disease patients and carriers, imparting health education keeping them hydrated so that RBCs do not have a chance to stick to one another, giving good nutrition, thereby adding folic acid, preventing infection by giving penicillin or erythromycin. Usually, routine immunopenicillin prophylaxis has been the thing, recognition of danger signs, and initiation of the comprehensive package. This is the primary care. Now, they come to the hospital for secondary care when they have developed an acute complication, the commonest of which is vaso-occlusive crisis, which leads to severe anemia and infections. They also come to secondary care when they have to initiate and monitor hydroxyurea therapy, or when they have to undertake blood transfusion and basic investigations. And of course, if they had one of those events for regular follow-up and coordination with tertiary care centers. Next, please. Next slide, please. Yeah. So the secondary care is the first referral point to primary care, basically for stabilization and initiation of disease modifying therapy. And then, of course, it goes to tertiary care. Next. Since I can't see the audience, I can't see the reactions, but I hope I'm passing my messages. So, role of the secondary care centers is very, very straightforward. FSIM. First referral point, stabilize the point, initiate the disease modifying therapy if available, and monitor and refer to tertiary care center as soon as possible if a serious complication has occurred. Next, please. So the sickle cell crisis, such as the vaso-occlusive crisis, the aplastic crisis, the hyperhemolytic crisis, the chest syndrome, osteomyelitis, avascular necrosis of the hip, priapism, and venous thromboembolism are dreaded complications of sickle cell disease. And early recognition is the main key to prevention. Sorry for the wrong word. So these vaso-occlusive crises, they result because of tissue ischemia. And look at where they affect. They affect the lumbosacral spine. So obviously they will actually delay or compromise the ambulation of the patient. They act on the just juxta-articular areas of the joints like the knee and the shoulder and the elbow, making your hand limited in its capacity to work to the best. Next. Now, this crisis actually lasts for 9 to 14 days. The prodromal phase may be recognized as the primary center because there's numbness and paresthesias, and the patient experiences pain. But once the pain is sustained and joint effusion and swelling are present, this complication has already occurred and he should be shifted to a secondary care. And the red lines indicate the care. And here you can see how the sickling pathway goes in to deoxyhemoglobin onto the postcapillary venule. Or this is the vaso-occluded vessel. Hardly anything reaches here. So there's hardly any oxygenation. And because of no oxygenation, the normal RBC become sickle-shaped. Next. So for a primary care, what are the simple indicators to run to the patient for secondary care? For primary care, it's abnormal temperature less than 36. Equally important, more than 38. A respiratory rate of 20 per minute in a child more than 4 years of age. With respiratory symptoms, with pregnancy, with headache, confusion or seizures, with joint swelling, and with priapism. Next, please. Now, how do you manage this? Very, very important. This has to be aggressive. And because there is pain, you have to give adequate analgesia. There are no biomarkers or imaging markers which can decide how to quantify pain because it's a very subjective parameter. So every vascular occlusive episode is an acute medical emergency. Rapid assessment and analgesia should be provided within 1 hour of arrival, and after every 30 minutes, you should reassess not only the pain, but the blood pressure, the pulse, the respiratory rate, the temperature, and the SpO2. If it is less than 95%, you should give oxygen. That should also be very carefully given because even oxygen is a drug. Next, please. So this is an assessment of pain, which is Wong-Booker's face pain rating scale, easily for everybody to understand. No hurt to hurts first. Next. So this is the mood scale, the relief scale, the pain scale, and how severe is it? Is it moderate? It's strong, no pain, mild, weak. I mean, this may not be easy to use by a non-educated work child, but these three are really easy to use. Next. So this is another Likert scale. Where exactly is your pain? And rated between 0 to 10. That means circle the number. How and similarly, when you have get your brain relief, when your mood is good, and when you're not drowsy or how drowsy, you would do this on the scale measurement. Next, please. So the now here this is the step ladder pattern to management of pain. You can initially go with aspirin and paracetamol, and sometimes, if the patient is very upset, you might need to give an antidepressant in a small dose. But if the pain persists and is not increasing, or is increasing in the next 30 minutes, add a weak opioid, which is actually like hydroxycodone. If still there is no relief, you have to add an opioid. Now, if this opioid is morphine, it's important to remember there could be serious side effects, and these children have to be in the ICU, severely monitored by a good staff nurse. Next slide, please. The pain assessment has to be done every 15 to 30 minutes. The antipyretics, antiemetics also need to be given sometimes, which could be prochlorperazine at the dose of 250 microgram per kg 3 times a day, or cyclizine 12.5 to 25 milligram 3 times a day. Oxygen saturation has to be monitored every 30 minutes until pain is controlled, and thereafter every 2 hours. Pain management should include 4 stages: assessment, treatment, reassessment, and adjustment. Remember, fluid management is important, but we have to avoid overhydration. And we'll just go and see why. Next. I think this you all know. Paracetamol, ibuprofen, tramadol, ketamine, and morphine have typical dosing, could be given IV or oral. The problem with paracetamol is its hepatotoxicity. With ibuprofen, it's a renal toxicity. With tramadol, is a respiratory depression. With ketamine, is a severe nausea. And with morphine, is respiratory depression. We have to be very carefully concerned about these. Next. So this is the same cycle: 30 minutes, 30 minutes, 30 minutes. Don't leave the patient till 2 hours plus 2 hours is complete to be sure that good analgesia, oxygenation, and hydration are complete. Next, please. Now, coming to the second dreaded complication, which is the acute chest syndrome. Next. So, this is the most common cause of death in children. And you understand so because lungs are vital to everybody. Now, how do you recognize this? This is the development of a new pulmonary infiltrate, which is accompanied by symptoms such as fever, chest pain, tachypnea, cough, hypoxemia, and wheezing. For those who have been trained in IMNCI or FIMNCI, this will get picked up as very severe disease and will immediately be referred to a tertiary care center. Now, ACS is a complication which occurs within 2 to 3 days after the onset of vaso-occlusive crisis. So, if a child comes to you in vaso-occlusive crisis, you have to keep the child admitted for the next 4 to 5 days to see, despite your measures, has he developed acute chest syndrome? Next, please. The pathogenesis is clear. It's most commonly infection with atypical organisms or strep pneumoniae, at times with asthma, bronchial hyperreactivity. But look at the other dreaded things. There could be bone marrow infarction and fat embolism because the vessels supplying a bone marrow also are end arteries and they can get occluded. Once they get occluded, there is fat embolism. This could go down to the pulmonary microvasculature, cause occlusion and inflammatory lung damage. Look at this cycle. Not only infarction, but there could be hemolysis driven lung injury. The free heme, which is released, it promotes inflammation and scavenging pathways. So you could also have a pulmonary thrombus. And because of hyperventilation and atelectasis, which is occurring because of the pain from rib infarction or opioid sedation, there could be shallow breathing, atelectasis, and precipitation of acute chest syndrome. So you can imagine one, two, three, four, five, six, five reasons why, and in combination, how severe it would be if more than two or three are implicated in the management of acute chest syndrome. Next slide, please. So the management is not very difficult. So those who understand ABG and can calculate the arterioalveolar gradient by measuring the PA2 oblique FiO2, you should start oxygen therapy if PaO2 is between 17 to 80 or SpO2 is between 92 to 95. Very important because this SpO2 is clinically not visible. You have to check it with the pulse oximeter. For this, you require a nasal cannula at 2 liters per minute, and that's good enough. After the patient responds, it's important to rehabilitate this patient. And for this, there is incentive spirometry. Most of you must have seen it. But this should not be given to a patient in pain. This should be given to a patient who is not sedated, not in pain, and is recovering from acute chest syndrome. Now, do we have any role for blood transfusion? So, yes, because if there's an infarction, specifically in the pulmonary vessels, an exchange transfusion is most effective. You're just exchanging the blood volumes. You're not actually giving a simple transfusion. So you're removing a lot of sickle cell RBCs and putting in normal RBCs. Also, because this could be triggered by an atypical or a typical organism, you will give a broad spectrum antibiotic or with macrolide, bronchodilators, and if bronchospasm is present. And very important to evaluate for fat embolism or pulmonary embolism. Hydration should not be so much that the lung is flooded with fluid, and rather than improvement, you cause pulmonary edema. Next slide, please. So, so that was about acute chest syndrome, its symptoms, its pathophysiology, and its management with recognition. Now, overt stroke and sickle cell. So there are children, there are areas where vaso-occlusive crisis is found. There are areas where stroke is predominant. There are areas where autosplenectomy doesn't occur and there's a large spleen. So this is one disease which in genetics is called pleiotropic presentation. Same mutation, different ethnicities, different presentation. I don't know if there was a chat box, I would have left a question and a chocolate for NHSRC to answer. If anybody could answer why this would occur.
There is a chat box. They
Yeah,
can
so
write
any
it.
answers coming in the chat box. Believe me, I will definitely give the chocolate. Dr. Nita Sharma, yeah.
Uh, Virtual
I
chocolate
don't want to be a
category.
false promise, right? Okay. So since nobody has answered, I'll tell you. See, sickle cell is one gene. I mean, beta globin is one gene. In the entire cascade of the RBC development, there are multiple genes involved. All right? They in turn also modulate the function of beta globin gene. So a change in those modulators is called a polymorphism. It was called a polymorphism. That means a change in the sequence of the DNA, which actually does not cause disease until and unless the disease is present, where its phenotype can be modified. So you can understand the sickle cell in Maharashtra, Gujarat, Odisha, Maharashtra, and sub Saharan Africa could be different because the other genes which influence the disease may be differently polymorphed. A little difficult to understand, but if you go into the depth of it, you would find out. And this is a food for thought and food for reading as well. Now, the stroke usually occurs because of intracranial artery stenosis, which involves a large artery, that is the circle of Willis, particularly the internal carotid artery and the middle carotid artery. Now, this actually is because of the injury to endothelium. And then, of course, there's a sequence of fibrosis which occurs. Next slide. Next slide, please. Okay. Now, coming to strokes, you can do a non-contrast imaging for strokes, or you could do a contrast imaging. Stroke is most common in homozygous SS. You require a transcutaneous Doppler usually, screening, and it should be available in most tertiary centers and centers of competence dealing with sickle cell disease. It is seen that 11% may develop strokes once there are 2 to 5 year old. The range is 0.2 to 0.79 per thousand. So it decreases as the years go by. It's higher in 2 to 5 year olds and lesser in 6 to 9 year olds. Next slide, please. So this is just a difficult slide. I don't want to navigate, but I would tell you that there is a role for MRI, there is a role for transcutaneous Doppler, and this should be available. But the immediate CT should be done without any contrast. And then one should decide, is it an hemorrhagic stroke or is it an ischemic stroke? Because a hemorrhagic stroke will require transfusion, while an ischemic stroke will require an exchange transfusion. So look at how important this decision is. You do an immediately non-contrast CT and find out, is it a hemorrhagic stroke or an ischemic stroke? If it's hemorrhagic, evaluate and treat and consider chronic transfusion onto him. But if it's ischemia, it's because of vaso-occlusion. If you don't remove the occlusion by an exchange with normal blood, you're not going to get rid of the stroke. Next, please. So treatment is exchange transfusion. The goal is to get HbS level to less than 30 and raise the hemoglobin to 10 gram per liter, not to be more over ambitious. 10 is the figure for hemoglobin and 30 is the figure for HbS. S3, H10. Just two simple things to remember. But if the exchange transfusion is not readily available, then you have no option than to give a simple transfusion, but the hemoglobin should be no greater than 10 gram per liter. The more the RBCs, the more they will sickle and block. Therefore, Exchange transfusion necessity decreases. You have to give supportive therapy, avoid hypotension, adequate oxygenation, euthermia, of course, all very important. TABC, temperature, arterial saturation, good breathing, and good circulation. Next, long term management, I told you 30%. If 3 to 4 years later, the transfusion requirements are much less, you can allow the HPS to remain 50. Initially, we are at 30. After 3 to 5 years, we can tolerate a 50%. Right. Next, please. So treatment the hydroxyurea is very good and it actually decreases the stroke recurrence by 3.6 events in 100% years. So it's really impressive, good drug. And you can also start prophylactic aspirin in those who have progressive vasculopathy. Rehabilitation, never forget, physical and occupational therapy, and also if they've had stroke, neuropsychological testing. Next, please. So primary stroke prevention, you use transcutaneous Doppler and you measure highest time averaged mean velocity. The short form is TAM well. TAM is time, A is averaged, M is mean velocity. So the normal is 170. If it is less than 170, it's low risk. Between 170 to 199, it's moderate risk. And more than 200, it's high risk. Just these three figures here. And I think this is God. So this is just how much you should do. Not very important. Let's go to the next slide. Yeah. So second, we come to renal complications. Now we've heard about, you understand that wherever there are end arteries, those organs are going to be affected. So the renal involvement uh, occurs because of chronic hemolysis and the harmful effects of filtered cell-free hemoglobin, hemoglobinuria, injury, and hyperfiltration. Development of CKD is a risk factor. I don't know what's wrong. This is moving. Just a minute. I will think quit something and yeah, right. I can go back now. So CKD, now if CKD occurs, just following CKD, you will get pulmonary vascular disease. It preempts the development of CKD. Next, please. So the third end artery is in the eye. Obviously, you will have renal ischemia and there would be neovascularization. So this is a mimic of retinopathy of prematurity. This reorganization could be non-proliferative or proliferative, and it may lead to retinal detachment and vitreous hemorrhages. And there are multiple stages. You don't need not remember that, but you should definitely remember evaluation of kidney functions, tubular functions, eye, transcutaneous Doppler as very, very important in secondary complications of sickle cell disease. Next, please. So when should blood transfusion be given? It is only very sparsely and specifically indicated, unlike thalassemia major. Simple transfusions are given in acute complications such as splenic sequestration. So all your blood has actually gone and pooled into the spleen and there's no peripheral blood. Even then you give simple transfusion, but do not build the hemoglobin beyond 10. If there's an aplastic crisis because of an antecedent parvovirus infection, you can be a little more less cautious and give simple transfusion. And in acute chest syndrome, with a target of hemoglobin to 10. But I told you, whenever there is a vasculopathy or a multi-organ failure or significant vascular occlusion, it is not transfusion but exchange transfusion. Long-term transfusions are primarily recommended after a stroke has occurred and the velocity is more than 220 centimeters per second on two successive abnormal readings. So, three messages here. The first message, be careful with blood transfusion. The second message, transfusion up to 10 gram per deciliter only in splenic sequestration, acute chest syndrome, and aplastic crisis. In all vasculopathies, exchange transfusion, long-term transfusions after stroke. Next. I think we can skip that. We've already done that. Next. Yeah, we've done that. Next slide, please. Yeah. So I'm going to go through the formula of all this, but blood transfusion is very different between children and adults. If you give them 10 ml per kg, their hemoglobin rise is only 0.5 gram per deciliter for each packed red blood cell. While if we give it to an adult, the hemoglobin rise is 1 gram per liter. It's different because the blood volumes are different, right? So it's important to remember that you might require a little more, but the hemoglobins are not so very indicative as much as the volume. Next, please. Now, if you're going to receive so many blood transfusions, obviously, you're going to be exposed to many antigens which are present, which are private antigens. So there should be an effort to reduce alloimmunization. So donors of similar ethnic descent should be considered. Blood should always be fresh and should be immunophenotyped. So all good blood banks dealing with sickle cell should have the capacity to do immunophenotyping so that alloimmunization does not occur and whatever you have transfused does not go back in 3 days' time. Second thing which you don't want to give is transfusion transmitted infections. So for that, you these infections are actually captured by the WBCs or the white blood cells. So you do leukodepletion or leukoreduction. So two things: transfusion, exchange transfusion, alloimmunization, and leukoreduction. These form the basis of treatment of blood in children with sickle cell. Next, please. Ferritin is not a good marker as it is in thalassemia. It should only be tested after first 10 transfusions. Now, ferritin is disproportionately elevated relative to iron for several weeks after a vaso-occlusive crisis because the ferritin is going to continuously circle with those vaso-occluded sickle cells. Therefore, the relationship of serum ferritin with total body iron is also not linear. So, unlike hemoglobinopathy, which is thalassemia major, a quantitative defect, serum ferritin is not a very good monitor, right? So, what will be the next monitor? Anybody in the chat box? No. The liver iron content. Next, please. So, the next is you commence chelation therapy in children normally transfused whose serum ferritin goes beyond 1000, whose liver iron concentration is more than 3.5 milligram per gram of dried weight. Remember, you have to do a liver biopsy here. Has received 10 transfusions of more than 120 ml packed cells. But the good marker that you should have, even if you don't have these at all, is cardiac T to MR, where it is 8 ms or less. So you required a transcutaneous Doppler. Here you require a cardiac T2 MRI. Next, please. So this was mainly secondary management of most of the crisis. There may be some which I may have left off. This I'm going to be brief because it itself is a big topic in itself. Implementation challenges in sickle cell anemia program will require another 30 to 45 minutes. So I'm just going to give you a glimpse of the challenges faced in screening of children with sickle cell, in treatment, and in management. Next. So there are challenges. What are the challenges? These children belong to remote geography, have poor transport to center, and there are logistic barriers. They have low outreach to non-school and migratory populations. These have low awareness and health literacy. They are not having adequate infrastructure and human resource, which include diagnostic tools, trained staff, lab facilities. They have social and cultural barriers, the fear of discrimination, social stigma and isolation, and resistance to prenatal or newborn screening. So, newborn screening for sickle cell came in the US in the year 1972. We are at 2026. So, if you can identify a child right at birth, imagine how much you would be saving. So 20 years from today, if India wants to eliminate sickle cell, newborn screening should be done in parallel with screening in the antenatal mothers, the college-going children, and educate the school children. There are policy gaps and implementation gaps. I'll take a next lecture if sir allows, sometime a little more in detail. Next. Next slide, please. So you require, so the take-home messages are sickle cell disease remains a major public health burden. Secondary care centers are pivotal. Hydroxyurea initiation and complication management should be carefully done. Effective management requires a continuum of care from the community to the tertiary referral, and reverse is also true. The elimination mission has diagnostic, geographic, operational, and socio-cultural challenges. Strengthening our workforce, infrastructure, and robust registries are essential for a successful program. But with coordinated public health efforts and improved access to comprehensive care, a reduction in mortality and morbidity is achievable. The last slide. That's an interesting slide. My last slide. So they are saying there's much more beyond what I've told you. So, you don't have any teachers now because Google and Wikipedia are all teachers. So I'm one of those running away from the scene because I may not have answered all your questions. But anyway, thank you for a very, very patient listening.
Thank you so much, ma'am, for such an insightful session. Ma'am, shall we take the questions now or shall we keep it for the last?
Whatever, I am okay with both. If there's
You
time
have to go.
constraint,
You
I
were
think we
not.
can go to the second lecture.
I beg your pardon, ma'am. Shall we take the questions?
Yeah, take the next question, next talk, and we can answer them together.
Okay, sure, ma'am. So moving forward, we have with us today Dr. Ritika Sood, ma'am. Just a minute. Moving forward to the next session of today's webinar, we have with us today Dr. Ritika Sood, ma'am. She is presently working as the professor, Department of Medicine, Lady Hardinge Medical College and Associated Hospitals, New Delhi. She has over 60 publications in national and international journals. She has chaired sessions and delivered lectures in several national level conferences. She has also been a coordinator and in charge of the Adult Thalassemia Care Program in Lady Hardinge Medical College, New Delhi. She's a core member of Medical Education Unit, and she is also in charge of Hematology Subunit at LHSMC itself. And her area of special interests are hematology. To add few awards and recognitions in her career, she's a recipient of Srimati Pavan Kumari Jain Award 2018 APIDSC and also a recipient of FICP in 2024. Today, she is going to take up the session on sickle cell disease at primary care, screening, crisis recognition, basic management, and referral. Over to you, ma'am.
Thank you so much. And I think it's a pleasure to be associated with NHRC to be able to discuss the subject of sickle cell care.
Ma'am, shall we share the screen PPT from here itself, or
I can share it from my end.
meanwhile, ma'am is sharing the screen of a PPT. I request all the participants to please ensure attempting both pre-test and post-test. It's only after we receive responses for both the test links you all would be awarded for the certificate of participation. I repeat, please ensure to fill in both pre-test and post-test link if you may wish to receive the certificate for participation. Over to you, ma'am.
So is my screen visible?
Yes, ma'am. Yes.
Okay. Okay, so just a quick background. Ma'am has already shared that that how hemoglobin, these are the commonest genetic disorders which are seen worldwide, and both thalassemia as well as abnormal variants of hemoglobin are a rather common phenomena in our country, and they constitute a major burden of the disease, and especially in malaria endemic countries. But because of global migration, it's almost become something that is global and not limited to our country. And it is prevalent more in the tribal population of central India and some parts of southern India. But again, migration has led to it also being seen in the non-tribal subgroups. So this is just a map just to give you an idea about how prevalent, sickle cell disease is. And sometimes, without this visual impact, we do not realize the extent. And so in yellow over here, you can see the states and the extent to which they are affected. So this percentage, includes both the trait as well as the affected individuals. So, but it is a rather large number, and we have a big job ahead, I would say. So, why is there a need to screen for sickle cell disease? But I'm sure once we've looked at the maps, we've looked at the numbers, we do understand the need and the urgency to screen for sickle cell disease, because as present, as you know, we've already seen in the presentation shared by ma'am, that there is no permanent cure for the disease. And with good management, severity, the severity and the complications can definitely be curtailed, and we can definitely improve the quality of life and increase the lifespan of our sickle cell individuals. And just to give a brief, this thing, I think ma'am has already talked about it, that we can have sickle cell disease when they inherit an allele from both the parents, which is denoted as SS. We can have trait when only one allele is inherited and one is normal. And we can also have the compound heterozygous variety when we have one of sickle and one of another variant. And a brief about the inheritance so that we understand, when we need to counsel at the primary level. We see this picture where you can see normal being denoted by blue, orange denotes a trait, and red denotes the disease. So if both parents have sickle cell disease, then all like there is 100% chance that the offspring is going to be born with the disease. But if we have one trait and one affected parent, then the chance is 50-50%. So it can be either the male or the female. So either ways the chance would be 50%. And if one parent has sickle cell trait and the other is no, one is normal and one is affected, then all of them are going to have sickle cell trait. Okay, so if one normal parent, then each of them is going to have a trait 100%. And if both parents have a trait, then there is a 25% chance of a sickler being born, and a 50% chance of inheriting it as a trait. And if we have a trait and a normal parent, then 50% chance of them being a trait and 50% chance of them being normal. So what is the impact of, in addition to this, what is the impact of sickle cell on the social and the economic conditions? So because sickle cell leads to a lot of complications, so there is a need for routine and lifelong care. And therefore, making, financial implications are many. So there are direct costs to the healthcare system, which would include the cost of screening, the cost of primary and recurrent emergency care visits, cost of drugs, hospitalizations, transfusions if needed, transplants if they are able to reach there, and a lot of other out of pocket expenditures which need to be borne by the patients. And there are also a lot of indirect costs to the family and the society, because each time the child falls sick, the parent needs to miss work to look after the child, and students missing school, and as they grow up, adults missing work days. And of course, there is loss of precious young individuals because of early mortality if sickle cell is not identified and treated timely. So definitely, the goal of the government of India is to eliminate sickle cell disease as a public health problem in India before 2047. So making, screening as the first step absolutely mandatory. And so the strategy is a three-step one: primary prevention, secondary prevention and screening, and holistic management, and a continuum of care. And the four main things that need to, which are part of these strategies, are awareness, screening, counseling, and management. So let's go through each of these pillars briefly. So, the aim of screening is early detection of sickle cell disease and traits. Because that is the thing that is going to help reduce the morbidity, mortality, and the disability that is caused by sickle cell disease. And it is important for us, not only that is why, to detect the disease, but also the traits, because we need to prevent transmission of the disease to the offspring. And we have tools for screening and diagnosis. So there are two ways that we can go about it. We can either use the one step approach, which by using point of care confirmatory tests, which have been approved by the government of India, or we can use a two step approach where solubility test is done, and if that is found positive, then we do a confirmatory HPLC to confirm the diagnosis. So now the solubility test is the one, which has is what we have been using for decades, and we can definitely call it the workhorse of the rural screening uh, technique, and it is a rapid and a cheap test, which is fairly, largely available in most of the centers, especially in the areas which are affected by sickle cell disease. And the point of care tests, which are based on lateral flow assays and optical spectrometry, are now available at certain centers and can be used. So the solubility test, which is available at most of the centers, has a lot of advantages and drawbacks. So of course, it is cost effective, making it ideal for mass use. It gives us rapid results, and within 10 to 20 minutes, you have an answer where, it can either be a yes or a no, and requires minimal infrastructure, does not require any electricity, cold chains, or advanced laboratory equipment. So making it very, very easy to use by any basic level staff, like the ASHA workers or the nursing staff in the remote PHCs in the rural areas. And but at the same time, with all these advantages, the problem is that it is unable to distinguish trait from disease. And we can have, falsely, it can be falsely negative in the newborn, it can be falsely negative in severe anemia, because there may not be enough sickle cell hemoglobin S that can be detected. It can be falsely positive in conditions where the lipids are very high, in hyperproteinemic states, and where the WBC counts are very high. And being a qualitative test, there is a lot of subjectivity in interpretation. So there is a lot of user dependence and how the person who is interpreting the test reads it. So, because the solubility test relies on the property that hemoglobin S is insoluble and precipitates in solution when mixed with a reducing agent in a phosphate buffer, and this reducing agent is usually sodium hydrosulfite or sodium dithionate. So, zero point zero 0.02 ml of whole blood is added to 2 ml of the reducing agent, and it is interpreted after 2 to 5 minutes at room temperature against a printed background. So this is what the test looks like. And you can see that, where the first test is positive because the solution becomes turbid, so you're unable to see the lines which are present in the background. While here, where it is negative, you are still able to see the lines in the background. Which I'm sure now you understand why is it so so if supposing you're not able to see the lines, or so it depends on how we interpret it, which makes it a little sometimes difficult to get the actual result. So, as part of the point of care testing, as part of the national sickle cell anemia elimination, the government has gone a step further and has approved point of care testing kits. And with this, we are able to, rapidly get a definitive answer to saying that, this is sickle cell trait or sickle cell disease, and get a confirmatory test in one step. And by the latter half of 2025, the ICEMA had validated almost 30 point of care tests and 5 non-rapid assays for use, across the states. And it is a one-step confirmatory approach at the sub-health center level, where an approved point of care test serves as the final diagnosis. And it can be used for universal screening of all individuals up to 40 years of age. In right now, it has been approved, or it is being used in 17 high prevalence states. And this is what a point of care, test looks like. So they are, tray based tests, and you need to, put a drop of blood in the well, and this is how you will be able to, get the reports. Depending on so this is a normal this is a sickle cell trait, this is a homozygous sickle cell disease. And making it simple and easy to interpret. And if we do the solubility test, it needs to be followed by a HPLC, which is considered to be the gold standard, uh, and is more reliable also for monitoring patients under who are already receiving blood transfusion or hydroxyurea. And sometimes it is unable to differentiate amongst the various variants which have the same retention time, like hemoglobin C. There we may have to do a genetic testing, and another alternative is electrophoresis, which can be used as a confirmatory test. The peripheral blood smear is the way finding or looking for sickle cell. But the preparation of these blood smears and slides is relatively simple, rapid and inexpensive, and again does not require any fancy kind of equipment. But though it is an informative test, it relies on a pathologist's skills, and we may not have trained pathologists at some of the centers, so thus limiting its use. And for neonatal screening, a dried blood spot is a simple and a quick test that uses the capillary blood from the heel that is collected at the point of testing, and helps us test the newborn. So who are the group of individuals who are going to be screened for sickle cell disease and sickle cell trait? So the target groups are in areas of prevalence are the newborn children from 6 months to 10 years of age, adolescents. Then premarital testing needs to be done, antenatal testing and prenatal testing wherever required, and testing of extended family members. So the group is rather large, and we can see that right from a newborn to 40 years of age, we can screen the various individuals, and based on the percentage of the percentage prevalence, they can be graded into four blocks, that is grade A, B, C, and D. So ranging from a prevalence of more than 30% to less than 3%. So in blocks A, B, and C, universal screening is recommended. But in those areas with a prevalence of less than 3%, targeted screening is recommended, where we are sure that where we are likely, that is, so in the extended family or during premarital counseling, if we encounter individuals there, that is the group where we need to screen. So now, what is the role of the community health officer in the target groups for screening? So as far as the newborns are concerned, so all public health institutions who are conducting institutional deliveries in sickle cell endemic areas, so all newborns must be tested, and we need to counsel the pregnant women to undertake the screening of newborns after delivery. And so we need to refer and ensure that all the newborns in the catchment area are screened. And as far as children from 6 to 10 years are concerned, then this can be done by the Rashtriya Bal Sevak camps, either at the camps, at the Anganwadis or the school. And of course, we need to support the team in screening children at the various centers. And adolescents, again, at at all primary healthcare facilities and outreach camps, must be screened. And similarly, we need to screen do premarital screening, and of course counsel individuals who are of marriageable age. We need to screen and counsel all couples at the facility and during outreach camps. And antenatal screening followed by prenatal screening, depending on the combination. So we'll discuss this a little more as we go ahead. And extended family screening wherever it is indicated. All individuals who are screened for sickle cell, they are provided with a sickle cell card. And the card is going to mention, so this is in areas that are endemic for sickle cell disease. So they are either going to be labeled as normal, carriers, or diseased. And all males are given blue cards, and all females are given pink cards. And now, based on the status of the card, the individual will receive treatment and counseling services. And then sickle cell cards will be extensively used for premarital and preconceptual counseling. Matching the cards of prospective matches, and matching of cards will show the chances of how the children are going to be born, either with sickle cell disease or as sickle cell trait. So this is what a sickle cell card looks like. So this is the front and this is the back, and each of them is given her Abha number or an Abha ID, and the details of the individual are mentioned over here. And the test report is also mentioned over here. For example, like over here it says that this belongs to a male, since the card is blue in color, and it belongs to somebody who has sickle cell disease, and the picture of the individual needs to be here. And this is of another person who has tested normal during screening. And this is that of a female. So depending on the status that is mentioned on the card, so the premarital counseling and other counseling and treatment is going to be advised to an individual. So, what are the outcomes of screening going to be? So, either an individual is going to be normal, so or an individual is going to have sickle cell trait. So, a person with trait would require counseling, that is premarital, and as well as genetic counseling. A person with sickle cell disease would definitely require treatment and counseling. So, management at the primary level is four pronged. It is preventive. And we have, I think, discussed quite a bit of the preventive aspect, because when we screen and each individual is aware of their status of sickle cell disease, we are able to, look at the preventive aspect, the therapeutic aspect, the rehabilitative, and management of crisis. So, the preventive aspect consists of genetic counseling, and it is the most cost effective way to reduce the incidence of these hemoglobin disorders. And genetic counseling includes premarital counseling, where we counsel the individuals about the risk of having affected children if they marry an individual with either trait or disease, with the help of the sickle cell cards that we've just discussed. And the same is about pre-conceptual conceptional counseling, that because individuals who have sickle cell disease need to understand that pregnancy in sickle cell anemia is high risk, with a lot of maternal complications such as worsening anemia, vaso-occlusive crisis, the acute chest syndrome, jaundice, preeclampsia, urinary tract infections, and a high mortality. And we need to counsel women with the disease or trait to get their partner screened, most importantly, before the initiation of pregnancy. We need to counsel regarding other reproductive options, and refer for a prenatal diagnosis for high risk couples. uh, when it comes to preventive management, so we all understand that prevention is always better than dealing with the complications. So if we are able to counsel them regarding this preventive management, counsel them regarding fluid intake, because dehydration tends to increase the concentration of the sickle cell hemoglobin in the red cells, and predisposes them to vaso-occlusive crisis. So we should ensure adequate intake of vitamins and micronutrients, protein-rich fruits like pulses and legumes, then zinc-rich foods, vitamin B, D, calcium rich foods. And so there is a whole list of foods, because sometimes just telling them that zinc-rich foods, B12 rich foods may not be enough. So we need to give them a list of do's and don'ts, and the kind of foods that they need to consume to lead a healthier life. And they need to consume carbohydrates which are with a low glycemic index and rich in fiber. Healthy fats should be used for cooking, like groundnut oil, mustard oil, and coconut oil. And it is always advisable to use locally available foods and oils for cooking and consumption. Then we come to the prophylactic management, where, of course, ma'am talked about the folic acid the use of the folic acid tablet. Then, prophylaxis against infections. So, oral penicillin V potassium is recommended in a dose of 62.5 milligrams twice a day up to 1 year of age, 125 milligrams for 1 to 2 years of age, and 250 milligrams a day till 5 years of age. And we definitely need to refer patients to the PHC for pneumococcal and penicillin prophylaxis. And iron supplementations should be started in case of iron deficiency anemia. So sometimes, we tend to miss out patients who may have concomitant iron deficiency anemia. So they need to be screened for iron deficiency. And all newborns should be given vaccines as per the national immunization schedule. And when we come to the rehabilitative care, so making sickle cell disease individuals aware that they can apply for disability cards is a very important part of rehabilitative care. As the sickle cell disease individuals are now a part of the recognized under the rights of people with disability. And because it is one of the 21 benchmark disabilities, so they also have a right to free education, some amount of reservation in education and government jobs, and higher education, and other rights that the PWD Act of 2016 provides to them. And when it comes to therapeutic, we have understood by now that pain is the commonest symptom that is felt by the sickle cell individuals, and this pain varies in intensity and frequency, and can sometimes even last from starting from a few hours to many weeks. And of course, we need to look for any triggers that may be triggering of the pain, like dehydration, fever, temperature, extremes of temperature, low oxygen, that is in high altitudes, and excessive fatigue. We must look for the triggers, definitely prevent them, and treat them wherever possible. For mild to moderate pains, NSAIDs in the form of acetaminophen and ibuprofen are usually adequate. But if the pain is severe, then we definitely need to refer the patient to a higher center. And we must also, understand that since these individuals are susceptible to viral and bacterial infections, so any fever or infection must be treated like a medical emergency, and they must, immediately be referred to a higher center. And pregnant women should always be advised not to self-medicate, and hydroxyurea must be discontinued at least 3 months prior to planning a conception. Just a few lines about hydroxyurea, that because it is known to reduce complications in those with repeated episodes of acute chest syndrome, and those who have more than 3 crises per year, and requiring hospitalization, so they must be administered hydroxyurea in consultation with a pediatrician or a hematologist after 2 years of age, in a dose of 10 milligrams per kg per day, along with other supportive care, and followed up for 1 year or more. And hydroxyurea is contraindicated during pregnancy and lactation. And while on hydroxyurea therapy, the following parameters must be monitored. So the blood pressure and the oxygen saturation must be monitored at every visit. The CBC count must be done every quarter. The liver and the kidney function tests must be tested every 6 to 12 months, and a urinary test whenever considered appropriate. And and also we must monitor for fever, jaundice, pallor, and spleen size on each health visit, and monitor the hemoglobin levels. So just very briefly about crisis management at the primary level. We have 4 kinds of crises that we may encounter: the vaso-occlusive crisis, acute chest syndrome, aplastic crisis, and the sequestration crisis. So vaso-occlusive crisis is usually precipitated by heavy exercise, infection, dehydration, stress, and extremes of temperature, and present to you with joint pain in the knee, elbow, vertebrae, chest, shoulders, and dactylitis, that is inflammation of the fingers and toes, giving them a sausage-like appearance. So it is important for us to identify a vaso-occlusive crisis, and differentiate it from the simple pain that sometimes they may be coming to. And treatment is, of course, pain relief, medication, hydration, and reassurance. But if it persists, and always better to refer to a higher center. And in case of a acute chest syndrome, which is usually precipitated by infections and overhydration, in children will present to you with wheezing, cough, increased tachypnea and fever. And in adults will present to you with chest pain, pain in the arms and legs, and shortness of breath. So whenever suspected, please refer the patient to a higher center. And because it would be difficult to treat at the primary level. When we come to sequestration crisis, so very commonly seen in children who are aged between 3 months and 10 years of age, usually precipitated by an infection. Whenever we notice sudden pallor, weakness, sudden enlargement of the spleen, worsening anemia, and shock, please suspect a sequestration crisis and refer to a higher center. And again, if there is an aplastic crisis where precipitated by a power B virus, usually the anemia worsens, and so refer to a higher center. And what are some of the other, indications for referral to a medical, officer or to a higher center? Is acute pain which does not, which is, not relieved by NSAIDs and hydration, which is always the first line of treatment when these individuals come to us. If it is not relieved in an hour, please refer the individual. If the pain is associated with vomiting and the individual is not able to retain any medication, if the pain is associated with fever, which is more than 38 degrees, if the pain is associated with respiratory distress and the respiratory rate is more than 24 per minute, or we have a saturation that is less than 95%, or if there is jaundice or cola colored urine or brown to black urine, it may be suggesting hemolysis. So we need to refer these patients to a higher center. And I think we've discussed most of the situations where we would need to refer, but also in addition to that, any acute abdominal pain with distension, any central chest pain which lasts for more than 20 minutes, if there is difficulty in breathing or an oxygen saturation of less than 25%, accompanied by hemoptysis or blood in the sputum, we need to refer. If there is a stroke, that is, if there is weakness in one half of the body or the various other distinct combinations which have been discussed by ma'am, we need to refer. Again, any kind of blood, any kind of priapism, acute worsening of skin pallor or jaundice, the cold, clammy skin, impending shock, seizures, and of course, all pregnant women and people, individuals with swollen feet, they need to be referred. So, just quick recap of what we've discussed so far. That adequate fluid intake is the most important thing that we need to, counsel the patients about. And even when they come to us at the primary level, this is one thing that we need to ensure. And painful crisis should be managed with NSAIDs, but not aspirin. And diets which are healthy, rich in the various vitamins and micronutrients have definitely, been proven to prevent any kind of crisis in individuals with sickle cell disease. And diets which are void of refined foods, which include refined sugars, fried foods, and alcohol, do help in prevention of sickle cell crisis. We have to counsel regarding any individual who may be smoking to stop smoking completely, to avoid crowded and unclean environments as well as high altitude places. Prophylactic antibiotic treatment is recommended at all times, and referral to an appropriate specialist indicated when the condition is refractory to standard care. So because they may not give us too much time, so we need to be quick in assessing and quick in referring whenever the need arises. So to conclude, I would say that sickle cell disease can have a devastating effect on the quality of life and greatly reduce life expectancy. And as primary care physicians, that there is a great responsibility. So having a good understanding of the mechanisms and the various aspects of management, which include the preventive, prophylactic, and rehabilitative, can go a long way in improving the quality of life and reducing premature mortality in our sickle cell disease individuals. Thank you.
Thank you to both my speakers. I think this was a very, very important topic, and both of you have excellently, very lucidly covered all aspects of management of these two diseases. And I'm sure the participants would have learned a lot. I was looking at the pre-test score and the post-test scores. Some of them have already done that. Pre-test scores were around 50 to 60% correct. Most of the answers, so there was some gaps there, but I see, whatever post test we have now, they are almost near, all correct types. So that means, the points were covered during the session. If there are any questions, I request you all to write this in the chat box. We can take these questions one by one. Meanwhile, Dr. Seema, you've been answering the questions, here, but there were one or two questions earlier regarding use of anticoagulation. I think Dr. Ashish Gupta had this question, and the role of prophylactic immunization for pneumococcal and seasonal flu in patients with SCD.
So, yeah, both of them are very good questions. Number one, any patient who has had a stroke, I did mention aspirin low dose should be given to prevent a CVT. That's very, very important. And other anticoagulants, I'm not aware of the long-term side effects of that. That's the first part of it. But anticoagulation is definitely indicated in an individual who develops a stroke and you find out there is central venous sinus thrombosis. What was the second part you said?
Prophylactic
I think
immunization.
I answered that on the
Okay.
chat box that there are three types of sickle cell presentations, In the Maharashtra variety, that means they have a modifier gene there. Most of them get autosplenectomized. You automatically don't get a spleen there. But those who have a large spleen and have to undergo splenectomy for hypertension, for hypersplenism, the lung disease gets worsened, and they should be given prophylactic much before splenectomy is planned, ideally 6 weeks to 3 months, with meningococcal H influenza B vaccines and pneumococcal vaccine. Now, because they are now in Mission Dhanush anyway, so we really don't have an issue. But earlier, this was a very important message before you ever splenectomize a child.
There is a question on what are the laboratory predictors of major complications in SCD in crisis?
Yeah, I didn't go through many of them. So there are the serum ferritin, not a good marker. But then you have a macrophage iron content, the liver iron content, the T2MR are three important measurable points that you see. A good transcutaneous Doppler, which has a good mean velocity, is an important marker. But there are many modifier genes if you have to look for them. But that requires a pattern which is called NGS, next generation sequencing, because many of the genes which upgrade HbF, if you have done a good analysis, will always produce a mild to moderate phenotype, while the reverse would not be true. So there are markers which are biochemical, markers which are cell signature based. Those individuals who have a high CD34 count will definitely have a higher HPF concentration and will have a moderate phenotype. So I didn't cover because it's a little too complex to cover for them.
I think basics were very well covered. Those who want, can read it. Maybe sometime we have a session on this. There was another question on screening. If both husband and wife are carriers, what is the risk of SCD in the child? I think you covered it, but it.
Yeah.
Uh, Here I would just like to say something, It's very, very important that when you genetically counsel these women and they have the spouse who's also a carrier and they have one affected child, you tell them there is 1 in 25% risk that your second child will be also similarly affected. The common question that comes in genetic counseling was, if I had to have 4 children, I've already had one. So my 25% chance is over, right? The quick answer to this is, अगर आप ताश खेलते हो और 4 ताश के पत्ते हैं, उसमें एक जोकर है, आपने हमेशा उसको घुमा के खेलना है. वो जोकर हो सकता है कभी भी ना निकले और हो सकता है हर बार निकले. तो चांस तो 25% है. इसलिए प्रीनेटल डायग्नोसिस has to be done in each and every pregnancy, and preferably by chorionic venous sampling between 13 to 14 weeks of gestation. If not possible, by amniocentesis at 18 weeks of gestation. See, the cost, this is a very good gene, a very small gene. The cost to a government sector on Sanger would Just the basic cost, not the manpower, electricity cost, is less than 1,000 rupees,
Oh,
right? So we don't need chips, we don't need the NGS platforms. Just Sanger sequencing alone will be good. The important issue that they have to consider here is in chorionic villus sampling, we take the sample from the placenta, considering that the sample is a fetal sample. But accidentally, we might take the maternal blood and amplify that, and that will actually show as a carrier, while the child could be truly affected. So, whoever does the chorionic villus sampling has to simultaneously do MCC, maternal cell contamination study. That means look at what are the signatures of the father and whether those signatures are present in the fetus, considering this is a true fetal sample.
I think that was wonderful, tip for people who are involved with the testing. Uh, uh, there is also a question about in a newborn, after how much time should the solubility test be conducted?
Okay, uh, I can answer that because I run the newborn screening program in Delhi, and in all the hospitals, including Lady Harding, they're getting screened for hemoglobinopathies, which include thalassemia, sickle cell, HBE, HPC, whatever, whichever, all the qualitative and quantitative defects. So there is no place for solubility testing in the newborn, right? You would just require 180 microliter of blood. That means 3 blood drops collected from the lancet from the lateral side of the heel. And from one of these drops, you take only 1.8 mm punch, giving you 10 microliter of blood, and the entire profile is there with you. HBS, thalassemia, HBE, HBD, HBC. If there is a doubt, on the same filter paper, extract the DNA and do the molecular. So there's no reason. I mean, newborn screening, not only for sickle cell, is now available in the US for 90 disorders. The single drop of blood. And I believe should be made mandatory as a program for, South Africa runs a newborn screening program only for sickle cell anemia.
Great. And it's all new for me as well to learn all these things. Then there is a question also about, if HPLC, both electrophoresis, both these tests are available, what should you be doing first, HPLC or electrophoresis?
Ritika, you want to answer? You want me to answer?
You can. You're an expert at it, ma'am. So,
So you know what? If you there are two different. No, I'm not talking about the paper electrophoresis or the starch agar gel electrophoresis, which were ones which were used in 1980s. Today we have high performance liquid chromatography or capillary zone electrophoresis. This is not the starch agar gel और cellulose acetate electrophoresis जिसका एक टुकड़ा निकाल के HbA to elute करते थे. These are no longer used now. Though the POCs are manufactured on that, the point of care tests. So if you're looking at sickle, they will only tell you sickle. They won't even tell you whether the trait or an affected. So now what you do is on the capillary electrophoresis, the first band, very fast band, is the alpha band, and the A2 and the E come A and the E come separately, right? So you can identify the fraction of HbF to HbA at birth. And if you have HbS, that comes separately in the sickle window. You can immediately decide, oh, there is a good peak of HbS. I have to do molecular for this child to show that he's affected. Correct? Now, on the other hand, on HPLC system, which is a very sturdy system, The management is on retention times. So on retention times, the peaks come. Now there are 200 types of hemoglobin variants, right? So you may get HBC coming with HbA, HBO Arab coming with HBC, right? So use of two complementary technologies or a reflex molecular testing should be the standard practice of care in high-end tertiary centers, right? And also look at the peripheral smear, correct? So if you combine these, the sensitivity and the specificity is 100%.
So, yeah, interpretation of these tests is also very, very important. How do you interpret these tests? Having technology available is one thing, but need to interpret these tests accordingly. And how do you go about, confirming the disease? Okay, now I think now we can move to the treatment part. Um, there is a question: can hydroxyurea be given safely in primary care facilities? I think people are
Yes.
very afraid of giving hydroxyurea here in primary care facilities.
I think I answered that online. There's a chart available, a chart, how many doses per kg body weight, and you can take for 10 kg child, for 15 kg child, for 20 kg child. And since there are not much side effects, the only question remains is, do I get more infections while I'm hydroxyurea? Does my fertility get affected? Dr. Ritika, who told you that you should have to stop both of these drugs if you're thalidomide or hydroxyurea 3 months before conception.
Conception. Yeah.
But these can be safely given at any level. I mean, the primary care level, because they will prevent some. That's why this elimination mission came. But
Yeah.
no, now we are moving towards gene therapy for sickle cell. So even if a child is affected, you can actually mitigate the entire sequence by gene therapy. And that, believe me, is an Indian initiative. We're not buying it from any other country.
This gene therapy is available in your hospital?
It's in phase 2 right now, will shortly be available.
Okay. So patients can be referred to you, once it is available. I hope it goes through successfully goes through these stages.
Looks like the initial results do look very promising.
Okay. And what is the cost involved? Would it
Uh,
be
I have no idea
okay? So
at
we
this
need
stage.
to work out those things.
That will be a CDSCO, Government of India decision. I have no idea about that.
Okay, regarding, I think you did cover this, but answered this in the chat box regarding the pain relief part and the use of more, opioids for the same. Because many times people are afraid of using this, and the availability also may be issue. What is your experience about, are these drugs available easily at the
Yeah. Number one, narcotic drugs are not available easily because you require a license.
Mm.
But most of the tertiary care hospitals have a narcotic license because you require them in anesthesia, you require them post surgery. And these people require definitely post hip arthroplasty because they develop avascular necrosis of the femoral head, and they have to undergo a complete replacement. That, believe me, is a very, very painful situation. So there are two methods now that you can give opioids. You can give them orally or you can give them by a patch. So the fentanyl patch available, there is hydroxycodone available. So if none of them work, then in a controlled environment where ventilation is possible, you can switch them to morphine. But I did show in my slides the side effects of all of them. I mean, even if I take ibuprofen, kidney damage, respiratory depression with morphine. So they have to be used in controlled environments, while patches, if the child is under supervision while sleeping and is perfectly fine, patches can be used. but they require a special two-drug form signed by the hospital doctor, knowing very well the indication and given only for the acute crisis period.
Crisis.
Because otherwise, this will become an addiction issue,
Addiction further.
right? So the moment the patient is fine for 7 to 10 days, step down to NSAIDs and then to physiotherapy.
For facilities where these opioids are not available, so they have to then manage with the NSAIDs only,
Yeah.
or they have to refer these patients to.
Refer
The
them to higher.
hydroxycodone is now available at most centers.
Hmm.
But yes, if they are not available and the pain is severe,
That's all.
they have to be referred to tertiary care center.
So is it just the pain relief part that they will consider, or if there are other complications, then only they refer?
So even persisting pain,
Persistent pain, yeah. I think I mentioned that in one of my slides
yeah,
that, pain
persisting
that
pain
is,
actually.
not relieved within an hour of, management with hydration and NSAIDs should definitely be, referred.
So just to tell you that once you have pain, there is an increased cytokine release, right? This
Yeah.
cytokine affects the nitric oxide pathway, which is anyway compromised in
Mm.
patients with SCD or sickle cell disease. So therefore, this pain has to be stopped so that the vicious cycle doesn't go on. That's the basis for complete good analgesia program for these patients.
Yes, I think this question is, answer is very clear. Pain relief, how this can be achieved at the lower level where these opioids are not available, and when these patients are to be referred promptly. So referral pathways should be very, very clear to everyone,
Yeah.
when and which patient they will be referring to. uh, so, ma'am, there is another question about, I think you did answer, but let me just read it out for others, also benefit of others. Sickle cell solubility test is mandatory for all children during RBSK screening or only for high risk groups?
Uh,
Um, So
maybe
I
you can
think,
answer it.
yeah,
Yeah.
yeah. So I think I mentioned that, that based on the prevalence in an area. So they've divided them into four graded areas, that is A, B, C, and D. So in areas A, B, and C, that is, where the prevalence is varying from 3% to 30%, universal screening is recommended. And only in areas where it is less than 3%, in those areas, they recommend targeted screening.
I have a very different opinion because that's why I asked Ritika to
Okay.
answer this question. When we are looking at very basic tests like solubility test, naked eye single osmotic fragility test. Many of this all has evolved to protect us from malaria, whether it is thalassemia or sickle cell disease. And believe me, where there is sickle cell, thinking that there is no thalassemia is not a question. So you should be using a much better method of detection than soluble testing. It has
Hmm.
been removed from 2022 guidelines completely because it is non-specific.
Yeah.
So the swollen cells, they will lyse and you can see those lines, right? That's the basis. How much scientific is the basis? How can I find a double heterozygote, a compound heterozygote, a co-elution of delta beta, E beta, E sickle, right? They will be going together because all of this has come from a descent. So we have to, now that has been removed from the primary care guidelines. But yes, if you have nothing better to do, no other thing available, and you have a high index of suspicion, then this does form the basis of first year testing.
Is CVS routinely available in government district hospital for fetal diagnosis of SCD? Are there maternal-fetal risk associated with this test?
Uh, to be very, very specific, no, they are not available in district hospitals. I did explain to you that taking CVS, because that time the baby is small, the amniotic fluid is little, you have to be an expert. For being an expert, you have to at least submit 20 good ultrasonographic images to the Fetal Medicine Society and do at least 25 procedures or 20, 25, I'm not very sure the number, a year, so that you actually are a good fetal medicine specialist, right? Now, on top of that, when you're looking at compound diseases and you're isolating DNA, I told you maternal cell contamination is a very important issue. So, similarly, analyzing capillary electrophoresis and then Sanger sequencing is again to be done in tertiary care centers. So, it currently does not look that either the gynecologist at the secondary level would be comfortable doing it. They may be comfortable doing amnio,
Yeah,
but not CVS.
serious.
Okay. There's another question on why SED patients are prone for capsulated organism infections.
Okay. So they are usually prone once you splenectomize them because the properdin levels, the opsonin levels, which actually protect against encapsulated bacteria, are very much housed in the spleen. So once you remove the spleen, you remove the entire cover of the opsonin and the properdin, right? So we have these important immunological agents which actually help us. But this is going to be no much of a problem today if Mission Indradhanush goes to the village because we are anyway covering, apart from meningococcal, we are covering H flu, we are covering pneumococcus. So it will be only meningococcal vaccine which will be actually required in today's date for prophylaxis.
And there is one more question about functional asplenia is a risky situation in SCD cases. Is the management of such cases to be looked at differently with respect to routine management in SCD?
Yeah, so I did tell you that there are even in India, the sickle cell phenotype in Orissa is different from sickle cell phenotype in Maharashtra and different in Orissa, right? You might get large spleens, but in most of the cases, what happens in some of these individuals, specifically in the Maharashtra variant, the spleen itself gets infarcted. So there is autosplenectomy or functional asplenia. Now, these are the patients who have to be put on meningococcal prophylaxis because if they have not received the mission on Dhanush, then they have to receive complete prophylaxis for all four organisms, right? Even those who have a big spleen but it's not functioning well, that is also functional asplenia. Even in that situation, your prophylaxis has to be good, both in terms of the antibiotic use as well as immunization coverage.
I think that completes the treatment part. I think last question. This is about the disability certification. This person is from Andaman and wants to know whether this is applicable there. Is PSC eligible or these patients to be referred to higher center for this certification?
Uh, so I think all parts of India would, I mean, they are eligible for this thing, and they would have to check with their, So right now, they can apply for it online and check where it can be done.
I think there is an online
Yeah,
portal.
there is an online portal where they can, generate a unique
There is
identification
an online
number.
portal.
Yeah, and they will be allotted a center
The only
based on
difference
their
is
location. Pardon, ma'am?
the only difference is that earlier you had to undergo a series of tests eye
Yeah,
examination, cardiac evaluation. Now the molecular diagnosis itself gives you a 40%
yeah. Entry into
disability,
the, yeah,
right? So this has
yeah.
been a very big issue for children who are anemic to undergo so many tests to get one certificate.
Hmm.
And this is something we should be actually closing down and making a government statement that only the molecular diagnosis should be enough for the disability.
Okay, I think, ma'am, can you also expand little bit on, the extent of deformity, disability they will get? There is a question for
Yeah.
SCD without any deformities, what is the percentage
So
of
around 40,
disability?
40%. Around
Huh.
40%.
Yeah.
And each organ damage, adds value. But even 40 gives you all the eligibilities for, as Dr. Ritika said, for all higher education, for government jobs, for travel,
I think this
right?
is a very, very vital for awareness part, because if we are not aware, we will not refer these patients. So,
Right.
Yeah.
we
So
need
the
to.
most of them they say कि disability तो बहुत थोड़ी आई है, इनकम टैक्स का बेनिफिट मिलेगा नहीं, बाकी सारा कुछ तो मिलेगा.
Yeah. Yeah. Yeah, and the disability scoring for sickle cell and all the hemoglobinopathies is now very, very objective.
Yeah.
Like as ma'am said, for like a diagnosis of sickle cell on HPLC or on genetic
Capillary.
testing, if it is available with the individual from a document, I mean, you just need the report and you will get 40% disability, and
I
it
think
is
the
benchmark.
name of the portal is UDAID,
Yeah, yeah, yeah.
Yeah.
It's the UDID portal.
Yeah. Universe, what is the full name for that?
UDID, Universal Disability. It's a UDID portal, I think.
You
I
can
don't.
just type this on the
I'll,
Google.
I'll, I'll do that. I'll just type it onto
Maybe
the,
you can post the link here in the chat box.
yeah.
They can save that. I think we are done with the questions round. There were plenty of questions, but they were all relevant, and I hope they were answered adequately. And I think we could not have had a more, apt person than Dr. Seema Kapoor and Dr. Ritika Sood for this, who've been, doing this for years together. More than 30 years, ma'am?
Yeah, more than 40.
40. Oh my God. So that was our privilege to listen to her, and sickle cell anemia. And I was, a little bit disturbed looking at the statistics that you mentioned in the recent survey. The prevalence is
It
so
got
high.
published yesterday.
Yeah. So that earlier I was thinking that it is concentrated in one or two few states only, but it is the magnitude, the prevalence is so high, and we need to address and look at it from the programmatic point of view is very, very important. So prevention is very important. I think best strategy, as always, is that you look for prevention, this premarital, prenatal, all these things, screening would do a long way. But I think there are a lot of challenges related to acceptance to this. So counseling plays a very, very important role. That people sitting at the periphery, if they are able to effectively counsel and get this screening done, premarital screening done, so perhaps in the long run, the magnitude, the size of the problem will decline. And as we see that there are so many complications, and they are also acute, and they need such an emergent therapy, referral, repeated referrals to tertiary care centers. So all this pain can be avoided if we manage these things properly at the lower level and refer these patients in a timely manner. Same day referral. And while you are referring these patients, be careful about the transport and the support provided during transport. Many of you may be sitting at very, very far away facilities which are not well connected, but if we don't take care problem during the transport, perhaps then we may be losing these patients. I think with this, I will like to thank Dr. Patni is also here. Sir, over to you.
Thank you so much, ma'am.
Uh, thank you, Dr. Sangeeta. As always, doing the heavy lifting of handling the questions as well. It's wonderful the way you are able to capture the essence of the discussion. Dr. Seema, thank you very much. You brought in from the latest published results, which I also heard for the first time. I have been involved in various policy decisions, if I may say so. But this, I'll also look up the report. It's just been published yesterday. And we also took the discussion into the future where we are talking of a sickle cell disease free India by 2047 through this gene therapy that you mentioned. That's wonderful. Dr. Ritika, it was a pleasure listening to you both together here, capturing different sides of the coin. Um, the bottom line remains that counseling, the most neglected thing, we always look at higher diagnostics and everything. Counseling as a method of prevention remains the most significant thing. And I'll never forget the way you mentioned, Dr. Seema, कि वो ताश के पत्तों में अगर रोक है तो चारों बार भी आपको मिल सकता है और कभी भी नहीं मिले. The most apt and very easy to understand. It was our privilege to host such accomplished speakers here. And I must say that usually these long webinars, being impersonal, a little bit of impersonal, towards the middle and towards the end, the audience tapers off. I'm happy to share with you that not only the audience stayed throughout, the numbers actually increased, and anyone who joined wanted to stay. So lucid and so valuable was the discussion here. Uh, Once again, it's the privilege of NSSRC to take these webinars to all our people. You heard people from Andamans had also joined today. We have some people who are regular followers and others who join in as things become available. Uh, One thing I had promised in the first session of this year is that we will be looking at getting the CME credit points for the webinars. I regret to inform that the DMC is, I don't think it is functional at the moment, so that did not happen. We have gone to the NMC now, and hopefully we will have those credit points very soon for all our participants. But do not forget to complete the pre and post test, because without completing those two tests, you will not be eligible for it. Shreya, what is the number of certificates you've given? Last I remember it was more than 4,000
Yes, sir. It's close to,
certificates, which are all, yeah,
it was close to,
close to 4,500.
yes, sir. Yes, sir. Yes, sir.
Yeah. So these are people who have actually qualified in the pre and post test. And we've had a very huge number of participants. So on behalf of National Health Systems Resource Center and Delhi Society for Promotion of Rational Use of Drugs, we thank both our esteemed speakers. It was a privilege having you with us, and we look forward to engaging with you in our future endeavors as well, not only for webinars, but also for policy decisions. We look forward to getting your inputs there. So with this, I'll hand over to Shreya, who's been patiently waiting her chance. Over to you, Shreya.
Thank you so much, sir. I'm really grateful for all the panelists who have joined us today for this webinar. My special thanks to Dr. Ritika Sood ma'am, Dr. Seema ma'am, Dr. Sangeeta Sharma ma'am, our advisor, QPS Division NHSRC, and to all the dear participants who have been with us today for the entire series of webinar. And thanks to the speakers who walked us through with the nitty-gritties of sickle cell diseases. I hope the knowledge that has been imparted to all of us will make us even more efficient while dealing with patients having sickle cell diseases. Moving forward, I would like to inform everyone the links for feedback and post-test links have already been shared in the chat box. I request you all to please attempt those. And also the upcoming webinar would be on 21st March 2026. It would cover topics on rational antibiotic use, stewardship principle for OPD, wards, and referral settings. Along with that, generic versus branded medicines, perceptions, counseling, and safe prescribing practices. I hope to see all the participants for the upcoming sessions. Jai Hind and have a nice evening. Thank you so much.
Thank you.
Just yeah, one thing to add. There were people were asking about. You can go to YouTube channel of NHSRC QPS division, and you can find the video recording of the session. So you can also access all previous sessions on this channel. And please share this with the others. Those who were not able to attend today, they can go through it later. See you next time. Thank you.
Thank you so much, everyone. Thank you so much.
Thank
See
you.
you. Thank you. Namaste and Jai Hind.
Jai Hind.